It is needless to say, as Anand pointed out, Dr. Charles has been one of the main innovators and a person who has made surgery practical, safe, and predictable for all of us. And today he's going to speak in continuation with his last talk, which was about 5 months back. Now he'll be speaking on a very interesting topic. And without much delay, I would request Dr. Anand to invite him for his talk on resurgery.
Thank you. Dr. Charles, please take it away. Your talk on resurgery, my approach and surgical strategies.
Well, thank you very much. It's a pleasure to be involved with my many friends in India. I feel like I'm a part of the country. Let me get rid of this other screen so I can see what I'm doing here. And then we'll start. These are the R words: reoperations, retinectomy, and what I call the reattachment sequence. I'm going to speak rapidly. So what do I mean by reattachment sequence? First, we remove the frontal plane vitreous traction. Why do I call it frontal plane? Because there's no core vitreous in PVR. It's the confluence of the anterior and posterior vitreous cortex, as well as anterior loop traction. Some people call that anterior PVR membranes, which is a misnomer. It's just contracted radial vitreous cortex fibers overlying the vitreous base that pull the equator of the retina anteriorly. The second step is the forceps membrane peeling with the ILM forceps. There's no need for PFO or anything at this stage. Spatulas are a bad idea. Scrapers are a bad idea. Use the ILM forceps and peel inside out. Subretinal bands need to be removed only if they change the retinal contour, if the retina is draped over a band. And I don't use the diathermy, nor do I use the cutter to make a gap in the retina. I do it by what I call punch-through retinotomy. I literally push over the highest point of the membrane, and I'll show you this graphically in a moment. Then I begin internal drainage of subretinal fluid. Don't use the term gas fluid exchange. You're not taking gas out and putting fluid in. Call it fluid air exchange, but do that after you initiate internal drainage. So you start draining through a retinal break or drainage retinotomy if there's no accessible break. And when the retina stops moving back, you say, okay, it didn't reattach all the way. Therefore, now it's time to add the surface tension component, which is fluid air exchange. So always initiate drainage first in routine detachments, not just in PVR. Then continue this drainage simultaneously with fluid air exchange. And if you see residual vitreous traction, don't take the air out and start over or put PFO in. Simply do vitrectomy under air, which I also call interface vitrectomy. Then as the retina begins to go back, let's say it was bullous, and now you're exposing a star fold that's limiting retinal reattachment, peel the star fold under air with the ILM forceps. It works just fine. Similarly, if you discovered a subretinal band at that point that's holding the retina up you didn't recognize before fluid exchange, you can remove it at that point. Then if the retina won't go back, then and only then do you do what I call incremental retinectomy. So you do the retinectomy under air. Don't do the Macula technique of relaxing retinotomy, and I'll tell why in a moment. And then once the retina is reattached, confluent laser, not spots, at the edge of the retinectomy and severed large vessels. Don't use diathermy to the full extent of retinectomy. That's too much necrosis. And then finally, air silicone exchange. So this graphically shows the sequence. So you see the arrows starting in the upper left-hand corner and then proceeding across the bottom. First, subretinal fluid, then fax, then vitrectomy under air if needed, then membrane peeling under air if needed, then remove subretinal band under air if needed, and then retinectomy if needed. Anterior loop traction is, again, radial fibers that were in contact with the retinal surface, extending from the posterior edge of the vitreous space anteriorly. Those must be resected. Today's 25 and 27 gauge cutters are just fine for that. There's no need for scissors as I used to use in the 20 gauge era. Macula invented relaxing retinotomy simultaneously with me inventing retinectomy. Retinectomy is better. Why? It removes all residual material anterior to the cut. That includes retina, the PVR tissue, vitreous. And if you do the retinectomy method that I recommend, which you see on the right here, that causes less epicellary tissue, less hypotony, lesthesis. I pulled my fellows via email, and on average, I have a hypotony case every 4th or 5th year. And yet it was 22% of the silicone oil study. Why? People do excessive retinopexy for 1, for 2, they do excessive buckling, and for 3, they do the Macula method and leave all the tissue anterior to the cut. Bad idea. What's the advantage of retinectomy under air? You do just the right amount. If you try to do it under saline, you're going to have, you may do retinectomy when it's not required. Often I'll think, well, I need retinectomy. Then I'll do internal drainage and fluid air. Turns out I didn't need it. Other times you can do unnecessary or excessive retinectomy. If you do it under PFO, these people that put liquid perfluorocarbon in every PFO PVR case, guaranteed to have it in the subfoveal space. When you got stiff retina, and particularly if there's a posterior break, and you pour in PFO, you're going to make breaks. PFO is essential for inferior detachments, and you leave it in place for 2 weeks. It's essential for giant breaks, as Stanley Chang taught us, but don't use it in PVR. It's massively overused. So again, I don't want to emphasize any point in this. I've already covered it, except the bottom point, and that is, don't do a lensectomy and then leave the capsule to put in an IOL in the sulcus at a later date. Simply do not do it. Why? The capsule sticks to the peripheral vitreous. It sticks to the back of the iris. The iris becomes concave. The pupil's fixed. The interocular pressure is low because of epithelial tissue. A very bad idea. It's very commonly done. Dean Elliott gave a talk at the Buccal Society, said the same thing. Don't leave the capsule. Yet numerous people do it. I see re-op PVR cases from other surgeons all the time that are coming to me for another operation. What are the common themes? Capsule stuck to the iris, pressures 3 millimeters of mercury, and they put a giant buckle around the eye, and all the PVR is posted to the buckle. What about if you've already got silicone in and the retina redetaches? Don't remove it. Operate under oil. Use the 1,000 Cenoscope silicone oil from Alcon, not 5,000. 5,000 has the same emulsification rate, and use the a non-valve cannula that are in these individual packs, and connect it to the Med1 BFI infusion cannula, which fits over it. Therefore, you can infuse oil with the VFC to make up the fluid volume as you remove subretinal fluid and do retinectomy. And you can peel ILM, you can peel macula membranes without adding any oil. But if you do a retinectomy and subretinal fluid removal, obviously you must top up the oil to make up the fluid volume. Surgery under oil, every technique that we use under fluid works fine under oil. That includes forceps membrane peeling in the diabetic case, scissor segmentation delamination for glial recurrences, retinectomy, subretinal band removal and resection, as well as endophotocoagulation. They all work well under oil. And don't use PFO with rigid retina. It ends up in the subretinal space. So this shows you membrane peeling under oil, which again works just fine. And this shows you actually a 2-port technique without adding oil much for epimacular membrane under oil. Lastly, why not scleral buckling? There's a funny story that's a bit derogatory toward Robert Macula, who got us started with vitrectomy many years ago. I saw a letter about a patient. He said the retina is substantially reattached. It was a letter to the referring doctor. It was completely reattached on the buccal, and all the retina posterior to the buccal is detached. The part posterior to the buccal is the part you see with. So putting a giant buccal in and looking in there and saying, oh, it looks great. And then they get PVR posterior to the buccal, and you got to do a retinectomy anyhow. So what's wrong with scleral buckling? It's massively overdone worldwide. I've done 8,000 of them. I haven't done one in 15 years. It's out of date. It makes the eye, on average, 2.75 diopters more myopic, as Ron Michael showed. It increases forays and trophies by 50%, as Ron Michael showed. And it causes pain, ocular surface disorder because of poor conjunctival closure. It damages the tenons and conjunctiva. If they ever need glaucoma surgery, it's much harder to do a trabeculectomy bleb or a tube shunt bleb. The operating times are longer, and it's far better to do a retinectomy instead of the need to support the vitreous space, as people say, with scleral buckling. That's all I wanted to cover at this time. So hopefully that will help you in your reoperation cases.
Thank you, Dr. Charles. That was a great quick take on what to do and, more importantly, what not to do for these 3 surgeries. So, Dr. Chawla, any thoughts on that?
Professor Dr. Charles, thanks for introducing very revolutionary ideas. I would just like to have a clarification on what you talked about scleral buckling. When you meant about scleral buckling, was it in context to reoperations or was it in context to even primary surgeries?
Good question. Because in the United States, but it'll happen more and more worldwide, patients insist on emmetropia. They insist on a quiet eye. When you buckle an eye, the encircling element, there's no way in the world you're going to ever get, if you do phaco-vit, you're going to get the refractive outcomes the way they should be. Patients want a comfortable eye. When you do a 360 peritomy and pull the conjunctiva up at 3 and 9, the patients get an ocular surface disorder. When you take the traction sutures on the muscles and rub them across the cornea while you're rotating the eye to put the buccal sutures in, they get epithelial defects, and people scrape the epithelium all the time in these buccal cases. Patients don't want an ocular surface disorder. One of my best friends is a brilliant scientist and attorney as well. And he got a buckle at Vanderbilt, and now guess what? He's got double vision, and because the buckle is acting as a fulcrum or a pulley under his rectus muscles. So patients don't like that. I want to achieve the refractive outcomes, the pain and discomfort and outcomes that you achieve with modern day cataract surgery, and you can't achieve that with encircling buckles. So it applies to all situations, but specifically to PVR. A common situation is someone does a vitrectomy to repair, say, a pseudophakic detachment. It doesn't work because of PVR. And on the second surgery, they do a huge encircling element. And now the patient's 3 diopters myopic, and the patient has a 2-hour operating time with lots of pain medicines post-op. Then they get glaucoma, and the buckle makes it so hard to do a filtering procedure. And it's unnecessary. Simply learn to use vitrectomy techniques to repair retinal detachment. Build your skill sets, build the techniques, and get rid of the scleral buckle. It's an anachronism.
Steve, I agree with you as far as the PVR situation is concerned, and also in most cases where, say, pseudophakic detachments, now almost exclusively we do vitrectomy only. But what about the young patients who present with a primary detachment where the vitreous, otherwise there's kind of intact vitreous, and a simple buckle takes care of their retinal detachment, and why invade the vitreous in those cases?
Yeah, what I do with this, in the typical young myope without a PVD, what the Brits call a round, I shouldn't talk about the Brits on Independence Day, but what they call a round hole detachment. What I do is put in the PFO, attach the retina with PFO, fill it all the way to the top with Alcon's perfluoron, laser the brakes. Then I come back in 2 weeks and a gentle PVD has been created by the PFO. So now the patient can stand up, walk around, go to work, fly in an airplane, so it's a great way to fix inferior detachments. And that's how I do it. Now, if it's a superior detachment in a young myope, I understand that I'm not going to make an aggressive PVD and cause more retinal breaks. So what do I do with the superior detachment? I use gas, and I tell the patient, the vitreous is still stuck to your retina. I may have to go back later and remove it, but I'd rather do that than do a big buckle and disturb the eye with scleral buckling. Now, there are a very, very few exceptions. I've had patients with an inferior detachment said, I've got to fly in an airplane tomorrow. I can't come back for 2 months. Okay, I put a buckle in. I had a lady that's pregnant with 3 months before delivery in bilateral infratemporal detachments. I did a segmental buckle in each eye, 15 minutes per eye without any sedation. So there are some unique circumstances, but instead of the young phakic patient, myope, the standard of care being a buckle, we need to move to the standard of care being a vitrectomy.
Dr. Pramod, your thoughts on what
Question
Dr.
on
Cyrus
Dr.
said and Dr.
Yeah, what Dr. Cyrus asked, that was my question. But also to add on, sometime you have difficult induced PVD and you have a multiple lattice degenerations peripherally. Again, typically you see these young patients with a detachment, and it may be breaks in a lattice, multiple 2 or 3 rows of lattices where practically vitreous will never separate. And obviously, you cannot just do good vitrectomy in that area. You want them to leave phakic also. So how you handle this patient without having buckling?
I'm comfortable with inferior detachment using PFO. If it's a superior attachment using gas, and accepting the fact I could possibly have to reoperate if the vitreous contracts later. I'm opposed to aggressive PVD creation that people think is the standard of care in these patients, because they do make other breaks, particularly in the lattice situation you described. So I'm opposed to aggressive PVD, and I'm opposed to buckle. That means I have to accept the fact that on occasion I'm going to reoperate. But when you operate with 25 gauge or 27 gauge, and you're not touching the conjunctiva except for 3 tiny little incisions, it's a comfortable, quiet eye, and it's a small price to pay compared to having a big buckle around your eye for the rest of your life when you're a 20-year-old myope.
How long you would wait? Typically, suppose you have to, do you plan resurgery in these eyes, or you just if it doesn't settle, then only resurgery? And if you plan resurgery, what will be the interval between first and second surgery?
Now, I would never plan resurgery, because many of the cases you can fix with gas alone. So it's not a planned thing. It's a as needed thing.
Sure.
Is there a time that you wait before you reoperate in a situation because you want the membranes to mature? Often we do, kind of find a situation where within a month after your operation, after a second operation, it is detached and you want to go back. So is there a time when you would,
Your point is well taken. The late Steve Ryan coined the term the life cycle of the disease. And it's a good term, waiting until, as you state, the membranes become mature. The late Ron Michaels also did an encircling element, which I wouldn't do, to reattach the periphery, and then did the vitrectomy months later. But a simple way to do it is when the eye's quiet, there's no cells in flare, that's pretty, and outside, there's no conjunctival hyperemia. It's kind of about the time these membranes mature. And that's typically once PVR starts, weeks, not months. But not days. So a couple, 2 to 3 weeks, something like that. So I'm delighted you brought up the point. It's a very important point.
Yeah. There's a question from the audience from Dr. Sumit Kandurja related to retinectomy under air. What should be the IOP setting for doing retinectomy under air?
Except in children and in people with real low perfusion pressure, like with people with dialysis shunts, I leave the intraocular pressure set, or the infusion pressure on the Constellation set at 45 millimeters of mercury in every case. Now, obviously not in children. Now, when the patients are under general anesthesia, which is unusual, I always tell anesthesia people, leave the blood pressure where it was. Don't make the patient so deep. If you want, we'll add a block, but don't make the patient, 70 over 40 blood pressure. Leave it 120 over 80 or above, and that way we'll have sufficient perfusion. But I'd love to have the IOP at 45.
And you mentioned that you favor 1,000 centistoke silicone oil to 5,000 because, as you rightly pointed out, we have also noticed that the emulsification rates tend to be similar. But are there any settings where you would prefer to put in 5,000 centistokes? For example, a very badly traumatized eye, this eye is going to collapse if you don't keep a long-standing tamponade in. So in such a setting, would you consider putting a 5,000 centistoke, or is there any setting where you would?
It turns out that there's a very complex calculation which goes by the name UGG, and I wouldn't attempt to try to explain it because I don't fully understand it. But it turns out that the long chain polymer average length, which is what drives viscosity, is a very minor factor in that equation. Interfacial surface tension is exactly the same between 1,000 to 5,000. They're both dimethylsiloxane. It's just that the bell-shaped curve, the Gaussian distribution of average polymer length, is pushed a little bit to longer chains to increase the viscosity. So in short, it doesn't make enough difference. So to summarize, there's no instance where I would use 5,000. It takes 5 times as long to inject, exactly 5 times as long to remove, and operating time counts. It's hard on the patient, and it's not efficient when we're trying to get many cases to the operating room in a day and save labor costs.
Yeah. You also mentioned that from minor, epiretinal membranes and reops of detachments under oil, subsilicon oil detachments, you prefer to have the oil in and then go in directly. But are there any settings where you would say in a non-emulsified setting? Of course, if it's emulsified, you need to take it out. But in a non-emulsified, what are your options? When do you remove the oil completely and then again go in and consider putting in oil again?
There aren't any, well, there's only one, I'm sorry. And that is the patient develops a cataract and needs a reoperation because of PBR. I take the oil out, do a lensectomy, strip the capsule with the forceps, and then check the retina carefully. Once I've got a good view, if I can fix it with gas, I will. If not, or if it's completely attached, I'll just leave air in there. But if it's complicated PBR, I'll reoperate the PBR and say retinectomy, and then put oil back in. So I only do it to facilitate lensectomy. I'm not a big fan of phaco over oil. Phaco over oil, you end up with a fibrous posterior capsule. You can't yag it. You have to remove it with the cutter, and it's just a nightmare. So if you break the capsule when you're doing phaco over oil.
So do you normally do a sulcus implant in these patients?
No, I don't. If there's oil in the eye, no implant at all. And I mean, a phakic capsule removed, but I avoid the sulcus implant that I used to use because the oil gets anterior to it and ruins the cornea. And the same argument applies to ACLs. I don't use anterior chamber lenses in that setting. Now, if you ultimately get the oil out, which hopefully we could do more in the future, but in many cases the oil has to remain. But if you get the oil out later, then I'll do a Yamani procedure or have our intersegment person do that. I very much like that procedure.
All right. So there's a question from Dr. Abhishek Agarwal from Sri Ganganagar. How do you manage retinal slippage and how do you avoid it? And retinal folds after retinectomy more than 90 degrees? In
giant break cases or just retinectomy?
Retinectomy.
Okay. Frankly, I just don't see slippage in the retinectomy setting. I mean, it seems to suggest an inadequate membrane peeling was done before the retinectomy. But on the other hand, why do I call it incremental retinectomy? You can't anticipate. Why don't I do it under saline? Because I don't know how much I need. And so with fluid air exchange and internal drainage, that you've got the retina almost reattached, and you make a little cut. You say, oh, the retina's attached. I'm done. Then you say, oh, no, I need more. I need more. I need more. Now the retina's attached. So if you do it under air, that surface tension helps you avoid slippage for one, and because you're removing subretinal fluid and infusion fluid simultaneously with removing retina that you must remove with membrane detached, you just get a better result. You're doing the right amount of retinectomy.
Dr. Steve, just one more question here. Now, to under air, when you do retinectomy, initial cut, do you use a cautery? I missed probably that part. Or you just start directly cutting with your cutter, and you said you use a laser over the blood vessels, right? You try to avoid diathermy there.
What I don't use the diathermy. I'm not opposed to the use of the diathermy. There are times when I regretted not using it to large vessels. But what I normally do is I just start with the cutter, as you suggest, and then I raise the intraocular pressure if any bleeding occurs. Then when I go back to laser the edge of the retinectomy, I also laser the vessel that bled, and then I lower the IOP.
What is your optimal time of keeping the oil in? You know, is it 3 months, 6 months, or what? How do you determine when to? You know, is there any time that you put? Minimum 3 months, I would leave it in, or what's the magic number?
There's no science to answer that question, and I find that a very challenging question. When the retina looks wonderful under oil, and we all know that when you remove it, you think you've got everything sealed up. The retina looks wonderful. You take the oil out, and the next day they're detached. That happens enough that frankly, superstition starts ruling your behavior, and you say, well, let's leave it another month. No, let's leave it 2 more months. There is no scientific answer to that, and it's frankly our biggest frustration. Now think about what happens when you do a vitrectomy. You've permanently reduced the viscosity 800-fold. You can't get a subclinical retinal detachment in a post-vitrectomy eye. That's why buckles don't work in a post-vitrectomy eye, because you've got an 800-fold viscosity reduction. And so the fluid runs through the tiniest little pinhole that's virtually invisible. And that's why you have this substantial redetachment rate. It's not just PVR recurrence or failure to remove membranes. It's tiny little holes that are challenging to see. Now, so what do you do about that? What's the conundrum? If you say, well, I'm going to make 27 rows of laser, the problem with that is that now you've got, well, we've got somebody's slides up.
Subhendu, can you just stop screen sharing for a minute? Yeah.
So now what do people do that are worried about that? They do a trillion rows of laser, and remember that PVR is a keloid. It's Mueller cell reactive gliosis, but it's functionally a keloid. It's excessive healing. So if you do too much laser to avoid the post-op leak problem, you engender PVR and epimacular membranes. And but if you don't, then a little pinhole can cause redetachment. So I think one of the things to come to grips with for all of us is occasionally we have to reoperate, but instead of this notion of instant reop, where you do a horrendous big sclerobuccal phaco-vit with 8 trillion rows of laser on the first procedure to avoid a reop, and have a 3-hour operation, and the patient takes pain medicines for a week, and it's got outrageous refractive outcomes. Why not do the minimally invasive surgery to get the retina attached? And if you have to reoperate, I've had patients I've had to operate 6 times, but they're ultimately attached, no ptysis, no hypotony, and no pain.
A quick question.
I definitely agree to your thought on this about pinhole breaks. There are cases where there is a buckle all around, there's silicone oil in situ, and you see a pocket of fluid at one place. And when you investigate that area by either a big imaging on a viewing system like Claris or like Optos, and then when you go in, you realize there's a small pinhole break sitting there. It's very often.
Absolutely. I agree.
Yeah.
I have a quick question to Dr. Charles. I like the term incremental retinectomy. So when you do 270-degree, the rest of the retina is still fine. Or in cases where it is still attached, how would you go, and what's the rationale of arriving at 270 as completing it to 360, Dr. Charles?
Actually, it was on one of my slides, but I didn't mention it. If I get to 270, I go ahead to 360, because my experience is that if I'm only 180, the inferior 180 is the most common one, I leave it that way. But once I get to 270, I said, okay, that remaining quadrant's going to contract post-op, I may as well go 360. I said that on my slide, but I didn't mention it verbally.
So if it's 360-degree, how do you prevent the auto rotation of the macula? It rotates on itself.
I'm sorry, I didn't catch that one.
So if it is a 360-degree retinotomy, how do you prevent the rotation of the macula? You know, the optic disc acts like a fulcrum and the retina rotates. So the macula is ectopic after.
I think if you do retinectomy under air, I don't see this rotation as much as other people are talking. If you do it under fluid, then you can get rotation. But if you do the retinectomy under air, I don't see the slippage rotation problem people talk about.
There's a question from Dr. Ashok Natraj from Trivandrum. How do you control bleeds under retinectomy edges when you're operating under air? How do you manage it there?
How do I manage bleeding? Is that the question?
Yes.
Raise the interocular pressure and use laser for hemostasis. We've obviously for years now used 532 nanometer laser, which is green, hemoglobin's red. So it's ideal for hemostasis because it doesn't cause damage to all the surrounding tissue. It only absorbs energy in the blood column.
Yeah. So the operator, what is you do not use diathermy? And this is question 2. Okay.
I mean, it's not bad to use it. It's just another step. If you're going to laser the edge of the retinectomy anyhow and laser retinal breaks anyhow, why not use it for hemostasis as well? And in diabetics, it's particularly important. When you do a diabetic traction attachment, diathermy is simply a mistake because you'll cause wider spread necrosis than you realize. And then a year later, there'll be a round hole and you'll say, oh, it's atrophic, it's ischemic. No, you made it with a diathermy.
The question from Dr. Chitranjan Mishra from Madurai. Is there any increased risk of glaucoma that you've noted if lensectomy is done and tamponade used and then a scleral fixated IOL done at a later date?
You can't do a scleral fixated IOL if oil remains. So you've got to get the oil out. And I don't think that the scleral fixated IOL, specifically the Yamane procedure, I don't do the adhesive bonding technique. If you do, and I never sutured the iris, I think that's a big mistake. It causes inflammation. So no, I don't think that the Yamane causes glaucoma. Now, use of subconjunctival steroids, which we all do, does cause that. So I've years ago, I used to use triamcinolone subconjunctivally in virtually all the patients, and I've long since given that up and use only Decadron, because with Decadron you have a higher immediate dose, but much shorter durability, and therefore you're not as likely to cause steroid glaucoma.
Thank you, Dr. Charles. That was a great session, and I think we could go on for an hour, taking questions and discussing this very challenging, very